I want to go quickly through a number of ideas. First, a little bit about the history of emergent development of safety ideas and thinking, the recognition that there are significant problems potentially in healthcare. It's a dangerous business. And to think about various ways we think about safety traditionally and then more recently, to understand the challenge of hindsight bias, which pretty much affects every kind of investigation we do because we already know what the outcome is. And if it's a bad outcome, then we look for things that might have led to it. And to introduce the concept of resilience going from safety 1 and safety 2, and I'll illustrate that. But as we've seen, not everything happens the way we want it to. Sometimes big surprises occur, and we have to be willing to anticipate the potential for surprise as well as try to understand the dynamics underlying the surprise. And this can be a patient who suddenly goes south. This can be giving the wrong medication when you think you've given the right one, but the bottles look exactly the same and you're in a rush, and there are usually several factors involved. And so when things go wrong, we get a little concerned about it, and we do investigations. And but this is not new. Back in the 60s, there were several papers, 50s and 60s, there were several papers, usually saying that the problems that happened were sort of the price we pay for all our new technology and our advances, and the fact that we can deal with things differently and more intensively than we could before. So in 1955, Barr talked about the hazards of modern diagnosis. Moser talked about diseases of medical progress and hazards of hospitalization. And in fact, in 1967, John Rudy in Montreal wrote 2 papers, one on adverse events and one on adverse drug events in the CMAJ. And that was probably one of the first papers actually to try to get a whole ward's experience with the frequency of adverse events. And it really wasn't until 2000 or 1999 when To Err Is Human came out that people had any sense of what the magnitude of this problem was. And they talked between 44,000 and 98,000 deaths in the United States. And the interesting thing about that study is that it was basically a summary of a series of studies that were looking at litigated cases, not non-litigated cases. So they're probably a lot higher if they had looked at wider. And in fact, the Australian study, the Canadian study, the figures they had were like 3.4%. The Canadian adverse event study found about 7.5%. The Australian study found 16% of all admissions had an adverse event. So much, much higher, which actually in retrospect was easy to understand given the nature of the source of the data that To Err Is Human used. So healthcare, as you can see here, is in the dangerous side, notwithstanding Egypt Air. Aviation is, in fact, ultra safe. The vast number of passenger miles that are flown without incident is staggering. Whereas healthcare is down there with mountain climbing and bungee jumping. And, I think this is something we need to sort of pay attention to. And of course, after To Err Is Human came out, people did start paying attention to it in a way that they never had before, despite some of the earlier indications that there was a problem. So what has been our problem with healthcare? Basically, the model that's used in almost all accident investigation is the individual components, people, and there are always people in healthcare, you can't avoid it, or processes fail to meet criteria. The model of risk builds on an assumption that safety, once devised and put in place and maintained by policies and procedures and rules, makes the organization completely safe and there will be no problems. That's basically the way we think about it. And people like Sidney Decker and Eric Holnagel and others, in the early 2000s, as people were getting alarmed about the problems of safety, we're beginning to question whether, in fact, that's the right model to think about how our healthcare organizations actually work and what they represent. course, there's always the goat that can be sacrificed in the name of patient safety. That's always a very effective mitigation process, but doesn't happen around here very often. But part of the psychological dynamic is that adverse events are a surprise. They're a surprise for the individuals who are involved in them, both the patients and the professionals. They are surprises for the organization, and they create a psychological dynamic where the organization begins to think seriously about its own policies and procedures and realizes that they are not foolproof. And this is very disturbing for organizations, that they are not doing the right things all the time, every time. And that the people in them, for reasons that we will have some discussion about, don't always do the right thing necessarily, or do something inadvertently that becomes the wrong thing. Mm-hmm. So we have to sort of understand that this is an important sort of psychological response, and then it leads to a whole bunch of things like, endless numbers of people dealing with risk management, because everybody wants perfection. They want no adverse events. There should be everything should be a never event, right? And, the reality is that probably isn't going to happen. But there's some other realities too, and we'll get to those. So the key features in healthcare, which I think it's true of a lot of other what we call risk critical industries. First, it's a complex adaptive system, so that there are a lot of factors at play and at work in the production of medical care and the management and treatment of patients. So demand pushes performance goals. There are lots of cutbacks. There's cutbacks in staff. That means the remaining staff have to do more work. You have to do it to the same level of professional quality. You have to get the same number of people, if not more people, out of the ward in order to be able to bring in the people from the emergency room. So there are a lot of demands, a lot of, in a sense, trade-offs between various goals of the organization. We call it a thoroughness efficiency trade-off. You can be thorough, but you can't be efficient, and you can be efficient, but you can't be 100% thorough. And that struggle is never-ending in healthcare. Of course, patients bring huge amounts of biological variance. No patient presents with a particular condition in the same way. And so we have to manage that. We also have to manage highly technical performance tasks. Even something like an infusion pump can be a real challenge if it's a different pump than one that you've trained on. The keypad can be the reverse of what you might expect it to be. Its ability to tell you when something is wrong might be different than what you're used to, the alarms. And all sorts of things can happen. And if you're busy and you're struggling to get through your day, this becomes a real challenge. You can inadvertently program it the wrong way, not really meaning to do so. So these are relatively simple examples of the kinds of problems one can get into. But I think they're real, and they're just one of many, many hundreds of kinds of dilemmas that people face. The rapid introduction of new technology, I'll have an interesting discussion about that later. And strong professional cultures, so autonomy and professionalism. We don't make mistakes here. But unfortunately, they happen anyway. So they question the organization's model and the professional's model of what they do and who they are. And in a sense, this is one of the things we talk about in patient safety. I'm not going to go into it in great detail. But there's always a second victim, if not more than one second victim, other than the patient who's had an adverse event. And it's either the nurse or the physician or a care aide or whatever. And one has to manage that situation as much as one has to manage the situation with the patient and the family. So here are the various models that have been put into place about how organizations think of safety. There's the Swiss cheese model, which you've probably all heard of, which, the Swiss cheese pieces are all sort of moving around, and sometimes they can all line up, and that creates an adverse event. You've got the domino theory. Once one thing happens, a whole bunch of other things happen, and then there's an adverse event. There are all sorts of other dynamics. And basically, organizations try to identify the risks. They try to eliminate or reduce them as best they can, as making the hole smaller in the Swiss cheese, or making them not so they can't align. And they protect against adverse outcomes. And these are common models that are used, sort of mental models that are used about what adverse events are all about and how you deal with them, how you can sort of conceptualize them and how you deal with them. So there are the old way of thinking and the new way of thinking. And the old way of thinking is sort of along the lines that I described. The system is basically safe. Human error is the cause of adverse events, and it's still frequently said to be the cause of the event. Unreliable people are the biggest threat to the organization, which is an odd way of thinking about it, but there it is. Progress on safety is restricting the unreliable component by rules, procedures, processes, regulations, and then everything will be okay. Well, the new view is to think of safety as an organization as not being inherently safe. Because if you get into the mode of thinking everything is safe and you don't have any adverse events, you will think everything is fine until, of course, you have the next one. And then everybody will be surprised and shocked and dismayed. Human error is not an explanation, but requires an explanation. Why did the people think it was reasonable to do what they did in the context in which they were doing it? This is a very different set of thinking, a way of thinking about what people are actually going through when they're doing the actual work of their day-to-day jobs. People create safety by recognizing risks and challenges and overcoming them. That's an important part to work around. It may be a workaround of a policy that doesn't fit a particular circumstance, and it may be that people get suddenly a sense that the patient is not doing as well as they think they should, and they begin to investigate and they realize something was missed, perhaps, and they can actually manage that before the patient actually has an adverse event. So people create safety in an organization, and so we have to honor that and think about how we can help build the capacity for them to continue to do that and do that more often. And progress in safety is developed by understanding the vulnerabilities and strengths of the system in which people work, so that part of the investigation of an adverse event has got to go very deep into how the organization actually operates. It's not just a question of somebody happen to be at the bedside, because there's always somebody at the bedside. You can always find a human being somewhere near a patient. Many human beings somewhere near the patient. But you have to understand how the system dynamics and the context in which they're working have aligned in such a way that an adverse event has happened. And by understanding that, you begin to go higher up in the organization and look at the more senior levels of decision making as to why did they buy that particular piece of equipment? Did they do the right human factor studies before it was purchased and brought into the hospital, for example? So if you don't look at that, it'll always just be human error. And then we're stuck and we're in a bad space, certainly from the professional's point of view, because then they just get blamed and they get fired or retrained or whatever. And there's you find somebody else comes in and the same thing happens and they get fired or retrained or whatever. And the organization pays no attention to itself as an organization and its contribution to the dynamics that underlie adverse events, almost always. So in complex systems, unpredictability and paradox is ever present, partly because of those key factors that I mentioned. New conceptual frameworks that incorporate a dynamic, emergent, creative, and intuitive view of the world must replace traditional reduce and resolve kinds of approaches. And that's sort of where we're begin to think about resilience engineering as a field which has thought about this in a number of different industries, complex adaptive organizations, has helped us move beyond simply reducing and resolving the quick fixes of the adverse event world. So David Woods, who's an engineer and has written a lot about this, from simple reporting to active investigation, really going deep and understanding what the dynamics were at the time of the adverse event. Accounting and looking for patterns. From accounting, simply saying you're accountable for this, to looking for patterns that might help you understand what the dynamics actually are. From retrospective reviews and investigations to trying to think about anticipating. What is it about the dynamic on the ward this morning that is different than it was yesterday? How are our resources being deployed? Do we have enough people? Do we have the time to do the stuff we need to do? Well, generally speaking, the answer is no. But how do we manage that? And if there's a discussion about that at the beginning of the day, it might very well mean that there's a much better capability of managing surprises as they emerge, even if it's not an adverse event, but a surprising finding in a patient, whatever, that you then can prevent an adverse event. So the point of investigating a critical incident in healthcare is not to find out who did something wrong, but to find out why people's assessments of the situation and actions made sense to them at the time. This is a fundamental change from the, you were there, you did the wrong thing, and therefore we're going to train you or you're going to be fired. You remember Susan Nellis, who went through hell because she was told, you have murdered these babies in the sick kids ICU, cardiac ICU. Well, it turned out actually that it was a toxic substance. It was a natural substance within the syringes, which actually read as digoxin, and it wasn't her at all. Mm-hmm. So, and a lot of people have had their lives completely ruined by the ascription of, you did this essentially intentionally. And what we have to understand is, why did something that became an adverse event, why did it make sense for them to do what they did? Did they misread a label? Were the bottles identical? Was a bottle that's pink and has a particular kind of cap have twice as much in it as another bottle that's pink and has twice as much of whatever substance is, succinylcholine? These are the kinds of situations where you're because you're busy, because you don't have a lot of time to read the tiny print on the bottle, you grab what you think is the right one, because somebody in organizing the pharmacy has put the two together. They've set you up, in a sense. And so you have to go looking at the underlying dynamics of what has become an adverse event in some detail. It's not a superficial process. And it actually, when you do it correctly, and we've had some experience in Saskatoon health region with this, it's very hard to write recommendations if you've done a really good investigation, because there are just too many factors that you would have to write a recommendation about. Yeah. And there's some things that you probably can't do anything about. And yet people demand to have recommendations because we're going to put in the recommendations and this will never happen again. Well, that's not the way the world actually works. So after the accident, it's quite clear, the person should have done something, and if they hadn't have done that thing, everything would have been all right. The decision making before the accident, though, is somewhat more complex. And this is what you have to try to understand. You have to, as we say, get into the tunnel and try to understand what people were thinking, the kinds of things that were influencing their decision making, what information they had, how they used it, etc., that led to making a choice A versus choice B, and choice A happened to be one that was going to lead to an adverse event, and choice B wouldn't have. But we don't know that until the accident has happened. And then tracing back becomes very easy. It's simple as pie. You should have done this. You should have zigged instead of zagging. Wouldn't have happened. And we have to get rid of that kind of mentality, because that is not useful. Understanding that complex set of dynamics in terms of the decision-making is what becomes helpful. Because it also begins to illustrate how the organization itself and its policies and procedures at high levels influences how everyday work gets done. And the tensions that you saw as the key factors before. So, let's talk a little bit about hindsight bias. I love hindsight bias. So it's natural for people to be biased by hindsight. You can't help it. You say, what could they have been thinking? Obviously, they should have done the other thing. Well, that's natural. It's a deeply ingrained cognitive process. You're not going to get rid of it. They're much easier to make than foresight judgments because it's a much more complicated set of dynamics before the event. It involves one explanation rather than many explanations or potential explanations or interacting explanations. And those are usually the ones that interaction, that dynamic nature of the decision making is usually what creates the adverse event, not any single one thing. And people can't be de-biased just by warning them. So if you rock back and forth, you will see these circles move. It's an optical illusion. It's like hindsight bias. They're not moving, but you see them moving. So keep that in mind when somebody says, oh, well, they should have zigged rather than zagged. So let's do one quick case study. So a 38-year-old male presents to the emergency room with cardiac arrhythmia. The physician who's experienced grabs a defibrillator, shocks the patient, doesn't work, shocks the patient again, patient goes into asystole and dies. So they try they try to resuscitate, can't be done, and patient dies. So, in retrospect, the physician realized she had failed to perform a synchronized cardioversion for the second shock. This is a clear violation of standard care and immediately raised concerns at senior administrative levels about the physician's competence and the need for additional education and training, as well as the possibility of disciplinary action because she violated standards of care. But this is what we call the first story. This is the classic, you did something wrong, you should have done something else, you should have known you should have done something else, and therefore, we have to train you or discipline you or maybe fire you, whatever. This is the first story. The second story is that, as the human factors specialist said, the likelihood is high that such an event could occur again. This particular defibrillator passively defaulted to an unsynchronized mode after delivery of the first shock, but did not provide any feedback or alerts or message on the visual display that this was actually happening. So the physician had, and there were other machines in the ER, same ER, that did do that. And this, somebody comes in and ventricular tachycardia, you don't want to spend a lot of time saying, is this the right machine? Is this the right machine? I don't know whether this is the right machine. Let's have a conversation about whether this is the right machine. No, you try to get the person cardioverted as quickly as you can. And if there are two options, one which is synchronized and one which isn't, and you can't tell the difference between the two, then you're being sort of set up for grabbing the wrong one. So the staff were unaware that the different machines were available, and the incident was facilitated primarily by a suboptimal interface design, which didn't alert anybody whom, not necessarily expected to be aware of these things. So the interface, which didn't give an alert or didn't give a warning, was really the problem, aside from all of the other dynamics that were probably happening at the same time. And it had nothing to do with human error. And you don't know this unless you begin, a really in-depth investigation. It's too easy to say, oh, well, you broke the rules, and we're going to discipline you and train you. Oops. So we need a paradigm shift. We need to go from thinking about human error as the only cause and thinking about the fact that human error is not an explanation, which traditionally is the way that people think of it. Oh, it's human error. That's the explanation. Well, no, it isn't, but it requires an explanation. And looking at things right is another way of thinking about it. We can do good investigations. They're retrospective. They're hindered by hindsight bias, but we can do good investigations if we ask the right kind of questions, if we ask the system level questions, if we ask about the context in which the adverse event happened. We can get a much deeper understanding of the adverse event. It's still retrospective. But we can take some of that learning and say, now we have some data from our good investigations, not our crappy ones. We have some good data. We can then begin to look for patterns on how the system can anticipate these kinds of dynamics creating this kind of problem. We can also ask ourselves another question, which is based on resilience thinking, which is the intrinsic ability of a system to adjust its functioning prior to, during, or following changes, disturbances, and new opportunities so that it can sustain the required operations under both unexpected and expected conditions, i.e. within the dynamic complex that it is a hospital ward or a hospital emergency room. You can maintain good functioning if you do a number of things. One is be mindful that performance variability is always present. You can't always do a particular thing exactly the same way every time, even though that's what the procedure said. The context is likely to be different. And so performance variability is normal and useful. What rules and procedures do is try to reduce performance variability. And what that does is it hampers people from being creative and working around situations that the procedures and rules maybe didn't think of. And being able to do that, yes, creates variability, but also creates safety. Safety management can't be based exclusively on hindsight nor on error tabulation. In fact, the reporting system we have in BC and many other places isn't very useful for pretty much anything. Yeah. You don't get much good feedback for it. A, there's underreporting, severe underreporting, and B, the investigations of even the reports aren't very good because there's not enough information, there's not enough time to do the investigations. So we're not even getting good feedback from the reporting system. So safety management has to be proactive. And it can be isolated from the core business. We talked about the efficiency thoroughness trade-off. It has to be thought of as being part of the core business. You have to look at the potential for trade-offs between thoroughness, efficiency, quality, safety, speed, etc. Cheaper, faster, better. That's the triple aim. You can't have all three. You can have two, but you can't have all three. And that's part of the trade-off that we deal with all the time. So when you practice resilience, you need to do four things. You need to respond to regular and irregular conditions in an effective and flexible manner. That's the actual. That's dealing with the reality you're dealing with, understanding its dynamic nature, and doing the best you can to understand what the underlying components of that dynamism are. You need to anticipate long-term threats and opportunities. Everything we do is potentially risky. I mean, they said that back in the 50s. So we have to try to anticipate what specifically might be a risky combination of both an invasive procedure and a very sick patient. Right? What are the things we need to think about? And we should be talking about these with our colleagues. What are the things we need to know? I have a friend called Ray Hill who works in Interior Health Authority, and he set up a really nice communication system for handoffs. And basically they ask one question: what do I need to know about this patient so that I don't make a mistake in managing? It's pretty simple. And it may be a lot that you need to know, but if you don't ask that question, you're going to get all sorts of information, and you won't know what the critical things are to know. And he's found that it's been very effective in helping what we call sense-making amongst the people who are receiving the patient, who have never had experience with this patient before. So that's a key kind of dynamic that helps people create safety, and is one of the important capabilities in anticipating what can go wrong. So that's the potential. We have the critical, which is monitoring short-term developments and threats and revising risk models based on those. We should be looking at our experience on the wards. What kind of problems have we run into? Have we run into a lot of problems of mismanaged medications? And do we have to go back and look at our medication distribution system on the ward to make sure that medications are, that seem to be similar but are very different, are not being placed in the same spot? Those are the kinds of things you can do proactively to reduce medication errors, for example. And you learn from past events, okay, as we discussed, with a good investigation. But you need all of these. because many of them are dealing with how you view the future, how you anticipate adverse events. Knowing something about the past adverse events helps, but they're never the same dynamic. They're always going to be a little bit different. There's always going to be some nuance that's going to be different in something that might happen in the future than what happened in the past. Although there may be some similar elements, and if you can understand the pattern of those similar elements, you can do a better job anticipating under the same circumstances. And if you communicate that to the people you're working with, then everybody will be on the same page about what that dynamic may be. And it's going to be different for different specialties and different wards. It's going to be different in the emergency room from the ICU, from the OR. But each one will have a pattern of things that have led to incidents. And that communication within the groups of people who work there becomes absolutely critical. So what is safety? White defines safety as a dynamic non-event. Okay. Safety is present when no adverse events occur. Okay. It's interesting. But it's logically impossible to study something that doesn't happen. So we need to think differently about this. We've sort of gotten on the idea that safety is something we can really study, but it's when nothing happens unduly, except normal work. And do we want to study normal work? Well, in fact, we do. Focus on non-events implies that nothing happens. But things happen all the time successfully. Most of the work that's done in healthcare is successful. So we have a much better opportunity of understanding how we can continue to be successful by understanding how that success is generated. And that's really what Safety 2 is all about. Safety 1 is traditional ideas about safety. It's actually accidentology. It's the study of accidents. That's Safety 1. Safety 2 is about how we manage complex, dynamic situations successfully. And we need to spend a lot more time thinking about approaching those things and having conversations about why things went well. It's not simply because, oh, well, we're well-trained professionals. Of course they went well. But we should not think of ourselves quite in such hubris terms, because you're bound to go for a fall, right? But you can say, yes, we do things well. We do anticipate sometimes. We do recognize small signals of something going wrong with the patient, and we intervene, and we save the patient's life. Or we prevent them from having a serious medication error. So we need to understand how that happens and celebrate those kinds of outcomes and have conversations about those kinds of outcomes, because we can all learn how we manage something successfully, because that's as important as managing something that completely went south. In fact, it's much more important because there are many more instances to learn from. So that's really what Safety 2 is all about. And detecting and managing discrepancy is really the fundamental issue. It's part of the anticipation. It's what I call the Miss Clavel effect. You remember Miss Clavel from Madeline. Mm-hmm. Miss Clavel turned on the light and said something is not right. Well, if you have your antenna up and you can use the Miss Clavel effect and you don't think something is right, you should probably act on it. You may turn out to be wrong, but you also may ignore it, and then the patient goes south. So having conversations about when you do and do not feel comfortable about things with your colleagues on the ward probably becomes the most powerful way of actually setting up a system of care that's going to be pretty successful. And it's something that, I can't really emphasize strongly enough, because if you just say, well, accidents just happen to people who are sloppy, you're never going to learn anything. And then it'll happen to you. And then you'll realize that that's a problem. I didn't realize how badly they felt. I didn't realize how complicated it was. And I didn't even realize I was making a mistake. Yet they're blaming me. And they're going to throw me out. Well, that shouldn't be happening. We should take a much better look. I mean, occasionally there might be somebody who's gone a little nuts and who's very upset at a patient and who does something egregious. And that kind of stuff happens too. But that's very rare. Anyway, so we need to begin to do safety one. I'm not saying get rid of safety one, because there's still things to be learned from a good investigation of adverse events. But we do have to move to look at how we manage successfully. We do have to talk to people about how they did something that really worked well. And go beyond, oh, well, I'm a good professional. I'm well trained. If we get beyond that, then we can have that conversation. And that becomes a very important source of patient safety, and safety too. So there we go, Miss-Clavell effect. So sense making and awareness of how the work is going. You need to have conversations about that probably 2 or 3, 4 times a day on a ward. How are we doing? How are we managing the stresses? How are we managing what's being thrown at us? Are we using our resources in the best way? Are there better ways that we could use our resources? Is somebody not feeling so well because their kid was sick? That kind of thing. That's part of the world. So that has to be managed as well. Anticipation, preoccupation with failure. High reliability organizations, as they're called, are preoccupied with failure all the time. What could go wrong? What would be the source of that thing going wrong? Is it a badly designed pharmacy? Is it a badly designed infusion pump? What? We've got to ask those questions and say, what do we think might be a threat in the environment in which we're working? And how do we get somebody to change that so that the threat doesn't exist? But do it by anticipating, not waiting for a bad thing to happen. Communication, I've mentioned the Miss-Clavell effect. Communicating and acknowledging concerns of other people. That's probably the most important part of person-to-person communication between professionals. Is if somebody's worried about something, you should pay attention about it. Pay attention to it and not dismiss them, saying, I'm too busy, I can't deal with it, blah, blah. Pay attention. It doesn't take very long. Have the conversation. It doesn't take very long. And if you begin to do that within even the dynamic of a very busy ward or emergency room or whatever, the whole dynamic of morale becomes quite different and much better. People feel appreciated by raising issues, even if they don't actually identify a particular problem, but might have. People should be rewarded for doing that, because that's the way you actually maintain an anticipatory, safe posture. Migration of authority. People need to have the authority to make decisions if they've got the responsibility for that decision. That's one of our biggest problems in healthcare. People don't feel they have the authority to do things. Sometimes they actually don't. And yet they've got the responsibility. And they're accountable. That's a triangle that can be problematic if the authority is not there as well. Functioning as a team, mutual support, that's in a sense what I've been talking about in terms of all the communication things we've mentioned. And acknowledging and rewarding success. People should take time out and say, that was really good. That really went well. Why? And then ask the second question, why did it go well? Let's do it. That's one of the great things about briefing and debriefing in the OR. It's a really good thing. A checklist might be useful, but only if it starts that kind of conversation. The checklist by itself is pretty meaningless. But if it begins to start the conversation about what went well, what didn't go well, what could we anticipate the next time, maybe we didn't realize the patient was going to lose so much blood, whatever. You begin to get into that dynamic and talk about what went wrong and what went right. And you try to understand how you understood the dynamics of the procedure as it was moving through its stages. Then you'll have a much better understanding of how you can work to either mitigate things that might have created a real problem, or just how you did things successfully so you'll remember to do that again. Not that it's, as I say, not every situation is going to be a little bit different, but you can get into some of the general principles of why things are really working well. And I think that's the takeaway messages. Healthcare has failed to fully understand the nature of success, of failure and success. The new view And resilience provides a deeper understanding, the beginning of a deeper understanding that, healthcare is not inherently safe. And, everybody who works in healthcare realizes that, but somehow they behave as if they don't believe it. And constraining performance variability is problematic because it creates, it doesn't allow for behaviors and activities that actually lead to success. And more rules and procedures constraining performance variability may produce more problems than they solve. Every solution can lead to unintended consequences. Never underestimate the power of hindsight. Failure and success are two sides of the same coin. Let's look at successful work. Success safety too may be more important to understand than failure. And it's not about best practices. I hate that term. And it's not about what we already do, because you don't. So don't delude yourself to think that you do this already. I've heard that too many times in situations where it was palpably not true. So let's be humble about this and say, okay, we can actually learn from a different perspective. It's not something we do, it is something new. And let's look and celebrate success. All these papers are instructive along the same lines that talked about, and thank you for your attention.